Namaskar to our audience. Welcome to today's session of Critical Lines. And today we have a very special faculty from All Indian Institute of Medical Sciences, Professor SHALIMAR. So, sir is a gastroenterologist and professor in the Department of Gastroenterology, obviously, at All Indian Institute of Medical Science in New Delhi, India's premier medical institute. Sir is he has been recognized as a top clinician scientist, figuring in the top 2% of global scientists in the world as per Stanford rankings. Recently, he has over 100 reputed uh, publications in various journals, and he's associate editor of the Journal of Clinical and Experimental Hepatology, and he's also a member of various editorial boards in various journals, member of Indian National Association for the Study of the Liver and the Indian Society of Gastroenterology. He's a very famous hepatologist figuring in many trials, etc., for liver. But today we are going to be talking about gastroenterology, and I'm sure we'll be hearing some wonderful comments and insights from Professor Shalimar, sir. So, sir, the first, I think, question I think would be most relevant to everybody is what are the recent advances in critical care gastro over the last couple of years?
I think, thank you, first of all, thank you, Dr. Bansal, for kindly inviting me to this podcast. And I'm very grateful and very happy to interact with you today. So I think there have been a lot of advances in gastroenterology or as such in critical care, there have been a lot of advances now. If we talk about advances, then advances can be in terms of the drug development, and advances could be in terms of therapeutics. Advances could be in the use of technology. So I think these are the few fields which I think have there have been a lot of new changes which have occurred. So in terms of drugs, when we talk about, yes, there are a lot of drugs which are coming up. We've got new molecules which are coming up. Whether we talk about diseases like inflammatory bowel disease, you've got new molecules which are coming up. The more advancements in the drugs are happening in the field of fatty liver, like disease which we now is recoined as metabolic dysfunction associated steatotic liver disease. A lot of randomized control trial coming up, and we're looking forward to the newer drugs being approved in this field. In addition, there have been advances in terms of treatment, like there have been use of uh, therapeutics like fecal microbiome transplant, and of late there have been instances of use of siRNA, and then this gene editing is something which we're looking forward to coming up in the field. Apart from this is technology. Technology has also leaped forward in critical care. As right now, we're looking at something like devices, which could be wearable, which could be watches, or it could be monitoring systems, which are now being used in trials and have shown to be effective in monitoring patients and help detect their complications early, and that can help manage these patients well. In terms of therapeutics, when we talk about, yes, like in the critical care, we're looking at management of, say, GI bleeds. So we've got now a lot of advances in terms of management of them. In terms of, we've got new devices, whether we have different types of clips coming up. We've got different types of even hemostatic powders, which can help in taking care of the bleeds. And we've got advances happening in terms of management of, say, complications of pancreatitis, like we've got endoscopic ultrasound, which is now being used for drainage of fluid collections, and its use is being expanding over time. We've got now is also in liver diseases, like for varicose bleed, TIPS is now coming up as a routine as preemptive TIPS. So that's the advance in the management of GI bleed. There are a lot of advances happening in the field of liver transplantation also, where we're expanding our use of the donors which are there. And I think the last but not to say is what we're talking today is that what COVID-19 taught us is the use of telemedicine. So that has also led to having experts on field talking and taking care of patients even when they are not in close proximity to the patient, but they can help in the management of patients. So I think these are a couple of advances which have happened over the past 2, 3 years.
Thanks, sir. Thank you for the answer. So you mentioned pancreatitis, sir. So just a very basic question about pancreatitis is hypocalcemia. So what is the physiology behind the hypocalcemia, and do you correct all hypocalcemia? When do you correct it, and the physiology?
Yeah, we do see hypocalcemia happening sometimes during in patients with acute pancreatitis. So when we talk about the pathophysiology, it is like in pancreatitis, there is release of lipase. So that lipase, when it's released into the surrounding tissue, it leads to conversion of, say, fatty acids, say triglycerides to fatty acids. So which then bind with calcium, and that's the way is what we call as the term called as saponification. That leads to a reduction in the serum calcium levels. In addition, there are multiple other factors. That's the one which I talked about. Lipase is one. Then there are other, like you got a SIRS happening, you got a lot of cytokine storms which are happening. And then there are like calcium is regulated by the parathormone. So any the changes in the parathormone get suppressed. So that leads to hypocalcemia. Then we've got hypoalbuminemia because which comes in patients with which is seen commonly in patients with pancreatitis. So what we have is the calcium which is bound to albumin is low, but then serum levels may be normal. And then other is like what we know is other causes of hypocalcemia like vitamin D deficiency, hypomagnesemia. So these are the reasons why we may have hypocalcemia in such patients. But then we don't treat every patient with low calcium. Only when you've got say, a severe deficiency of calcium, patient is symptomatic, then we treat. And treatment involves, as in management of any other hypocalcemia status, that we can correct them by giving IV calcium gluconate and then correction of magnesium and vitamin D deficiencies if they are there. And also more important is to take care of sepsis and other dyselectrolytemia and other electrolyte imbalances that need to be taken care of while managing hypocalcemia in patients with acute pancreatitis.
Thank you, sir. So moving on to the liver, sir, about hepatic encephalopathy. So everybody knows that ammonia is deeply associated with hepatic encephalopathy. But can you just tell us a little more about the pathogenesis and also the treatment and various disease states such as chronic liver disease, ALF, and ACLF?
So I think ammonia is one of the players in hepatic encephalopathy. It is not the only player. So there are multiple things happening in a patient with, say, acute liver failure or chronic liver disease. It's what we call as cirrhosis or acute and chronic liver failure. So the other factors which play a role in the pathogenesis include is the most important is the SIRS, again, that we talked about in pancreatitis, like any critical illness, as we are talking today on critical care especially. So when there is a lot of SIRS which is there, which leads to then again is the cytokine storm which comes along with it, leads to increased permeability of the blood-brain barrier. So once that's the blood-brain barrier is more permeable, you've got more toxic things moving in and out of the brain, and that is one factor which plays a role. In addition, what we have is multiple other factors which play a role, like a thing which is coming up now is gut dysbiosis. That is the imbalance between the good bacteria and the bad bacteria in the gut, which possibly also play a role in the pathogenesis of hepatic encephalopathy. In addition, there are a lot of other factors actually which we need to keep in mind while we are evaluating a patient with hepatic encephalopathy. That includes factors like sepsis, then is dyselectrolytemia, hypoglycemia. I think these are other factors which we need to keep in mind while managing a patient with hepatic encephalopathy. The other factor which also plays a role in what we commonly see is sarcopenia, which is another factor which contributes to the like muscles play an important role in the metabolism of ammonia. So the ammonia metabolism involved is the muscle, the brain, liver, and their GI tract. So an imbalance which happens in either of these four organs leads to also hepatic encephalopathy. So when we are looking at such patients, one, we need to ensure that yes, we are targeting the treatment for hyperammonemia, which is usually seen in such patients. But then if you've got a normal ammonia, that essentially takes you away from a diagnosis of hepatic encephalopathy. You need to start thinking that the altered sensorium in this patient may be because of other factors like a neurological cause. So if ammonia is normal, I think that should raise a possibility that possibly you're not dealing with hepatic encephalopathy. If it is elevated, then hyperammonemia may be because of multiple factors. It's not um, uh, the only factor which is responsible for the hepatic enceph. Ammonia rise may be seen in per se sepsis, uremia, and dyselectrolytemia. So this is something which we need to. So while treating such patients, we manage as such in any critically ill patient, take care of the patient's hemodynamic status, take care of the dyselectrolytemias. Then coming to specifics of treatment of hepatic encephalopathy, that includes is the use of drugs in the form of lactulose and rifaximin. Then we have got drugs like L-ornithine and aspartate, which is being used. And there's a lot of now data in terms of possible use of some kind of probiotics being of benefit. Then is the use of like the what we are taking care of is the precipitating event. So we take care of all those events. So then there is also an upcoming role, which is recently few small sample size studies have come up showing a possible role of fecal microbiome transplantation in the treatment of patients with refractory hepatic encephalopathy. So this would be the pathogenesis and the treatment of hepatic encephalopathy in a nutshell.
Yeah, and sir, specific to acute liver failure and hepatic encephalopathy, mannitol and all those things, albumin, mannitol, dialysis.
Yeah. So when we talk of specific is like we're looking at ways how we can reduce the ammonia. So we can reduce ammonia by the drugs which we talked about. So somehow L-ornithine L-aspartate doesn't work in patients with acute liver failure. Then addition to that, there is not much of data of use of lactulose and rifaximin, but then these are commonly used in patients with acute liver failure. Lactulose is usually avoided in patients with acute liver failure as leads to more abdominal distension. And then if a patient is being considered for transplantation, then it may have some effect, or say it is not something which a surgeon would like the gut to be distended. Then there are mechanical ways where we can use to reduce the ammonia levels. That includes the use of dialysis. Dialysis in the form of continuous renal replacement therapy has been shown to reduce ammonia levels. In addition, plasma exchange has also been shown to be helpful in reducing ammonia levels. So in that way, we can target with the use of these support devices. The other support devices, unfortunately, have not shown to be of much benefit, like devices in terms of Mars, Prometheus, that have not really shown to be of benefit in patients with acute liver failure.
Right, sir. So then sometimes we get these patients with altered sensorium and LFT is normal. So can these patients also have hepatic encephalopathy with a normal LFT at times?
So, in a patient with normal LFT, that makes the diagnosis of hepatic encephalopathy little unusual. We need to start then thinking of other possible causes. That could be any cause involving the neurology is like in the brain, something's happening. We need to look at the dyselectrolytes. But then one thing which can explain with everything is the presence of a shunt. Like shunt is there is a shunt between the say the portal vein, the splenic vein. So where there is a spontaneous lenorenal shunt, that is one situation where you may not have very significantly, where you may not have even derangements in the liver function test. But then we're looking at something that as an unusual cause, because there would be some amount of effect on the liver to manifest, and then the liver is failing. That's the reason when hepatic encephalopathy happens. So you should have some derangements in the liver function test. So if a liver function test is unusual, I would suspect that possibly liver is not the cause for hepatic encephalopathy. And then it's a patient is probably not having hepatic encephalopathy. We need to start looking at other causes of altered sensorium in this patient.
Right, so thank you, sir. So then moving on to nutrition. Uh, we have these patients all the time who have to be started on some kind of nutrition, sepsis, septic shock. And we know enteral nutrition is contraindicated because gut absorption is not there. Vomiting can occur, ileus can occur, and mesenteric ischemia, bowel necrosis can occur if you feed them in shock enterally. And TPN is also contraindicated in these patients. So would you throw some lights on why TPN is contraindicated in these patients who are in shock, septic shock, other kinds of shock?
I think the same reason why enteral is initially is contraindicated, because like in TPN, what you want is the blood flow to the various organs which are really important for keeping the patient alive. So we're looking at blood flow predominantly to the heart, probably to the brain. Now, if you give enteral, then again, there is a lot of blood flow going into the GI tract. So that will lead to a lot of dynamic changes in the, or say the flow of blood will be altered, and then the target organs where you want to maintain a good flow will be affected. So same thing happens with TPN. Is like TPN, when you're giving is one in a critically ill patient, you are more inclined to ensure that there is the patient's maps maintained, saturations maintained. Now, if you give TPN again, then there would be a lot of one, you will be adding up to a lot of fluids which are hyperosmolar, which have lots of lipids. And then you then expect, there's like when you give such kind of fluids, you expect the metabolism also to happen now. And if the metabolism is active in, because to take care of these, the mitochondria also become active. That leads to a lot of then is physiological changes in the blood flow. Then the blood flow which you really want to go into the brain and the heart will get affected too. Is then this also leads to, because it is hyperosmolar, it leads to more diuresis. It may lead to more, and then changes in the electrolytes. Plus, when you're pumping in so much of fluid, you expect dyselectrolytemia, and then fluid shifts will happen. So overall, and even if you were giving this, like it also will lead to more of hyperglycemia, which you really don't want in such kind of patients that may again have issues. And we know that use of parental nutrition is also you're going to use with lines. So, and the use of lines in a sick patient also contributes to increase more risk of infections. And then we also have is like use of TPN may also cause cholestasis in the liver, and then you may have liver enzyme derangements in such patients, and more of fatty liver disease, and may have liver dysfunction in such patients. So I think these are the reasons. And then other is a refeeding syndrome is another thing which more of associated with its own dyslipidemia. So these are the issues which arise when we use TPN, and then we're looking at more of fluid to be given in an appropriate amount and to maintain the perfusion of the major organs. That is our aim in a critically ill patient. And then once that's taken care of, then comes the nutrition as in the later parts of the management of such sick patients.
Thank you, sir. So moving on to the last point, sir, you mentioned briefly about probiotics and prebiotics. So first, sir, can you just explain what are prebiotics and prebiotics and probiotics, and what is their role, pros and cons in critical illnesses? Because our guidelines, they don't mention the use, especially in sepsis. So if you can just kind of elaborate on these drugs, or if
Yeah. Yeah. So probiotics are live organisms which are either bacterial or yeast, which have some benefits. That's what is being proposed as. That's how they are being used for possible that when we have now is some kind of gut dysbiosis in this is there. So gut dysbiosis is in most diseases, but then we really don't know, and we're not really sure, is this gut dysbiosis the cause of all these diseases, or it is a consequence of the disease which happens. Because when a disease state, so that is still not clear. And I think we are really over time we are understanding how this gut dysbiosis plays a role in the pathogenesis of disease. So probiotics are these live organisms which we hope that the changes in the gut microbiome which happen in a disease stage we can reverse by giving them. Now probiotics have different types of concentration, different, there are so many formulations which are available. Which is the best, we really don't know. And how much do they benefit, again, is again a big question. So but then there is evolving data on probiotics in multiple diseases, like say is in stable patients. I'm not talking about any critically sick patient. In a stable patient, yes, some amount of benefit has been shown in patients with antibiotic associated diarrheas. Some amount of data is also coming in liver diseases in terms of hepatic encephalopathy, though plus minus role in also in the ventilator associated pneumonia. But then actually we really don't know, like in a critically sick patient, when we're talking about, there is a problem in the gut barrier. So when we give so much of these organisms, do they spread from the GI tract, and then they go systemically and cause more infection? So our concerns more in such critically ill patients is, do giving such kind of live bacteria would cause more harm? So that data is really not available. And in a critically ill patient, there are no recommendations for use, and possibly they may have some benefits or maybe some harm. So that is something which we need to we need more data on that aspect. So coming to the next point of prebiotics, prebiotics are actually something like non-digestible food items, something like what we eat in fruits and fruits and vegetables. So these are fibers which actually stimulate the growth of these bacteria, and then that help their promotion. So I think we need still more data regarding the use of these pro and prebiotics in critically ill patients, but have some benefit in non-critically ill patients. But the data is still evolving in patient. What's the real utility?
Finally, sir, you just mentioned about the microbiota of the gut. So, anything else you want to add, sir, as far anything concrete, anything is there to talk about in critically ill? I mean, in liver
So
disease and all. So, whatever you want to talk about, sir.
no, so in critically ill, when we're talking about any kind of these probiotics, prebiotics, so as per the current literature, no, their use is not recommended. We need more data. How much benefit are we going to get, or do they cause more harm? I think we need more data on that aspect. So till the time that data evolves, I think we need to be very, very careful when we use such bacteria in a critically ill patient.
Right, sir. I think that was wonderful, Professor Shalimar, sir. And we have a very good audience also. We'll put this up on our channel. And with that, we'll conclude with your permission. Thank you very much, sir. Look forward to having you again on our channel. Thank you to the audience for their patient hearing.